This is Dr. Joaquim Bellmunt. I'm an associate professor at Harvard Medical School and director of the Bladder Cancer Center at Dana-Farber Cancer Institute in Boston. I have been attending this ESMO meeting, and I can talk to you about what has been presented in terms of urothelial cancer. I think we have heard a lot of new data on biomarkers, a lot of exploratory biomarkers, but likely this is setting the future for development and establish designed trials exploring these biomarkers. I was a co-author of the late-breaking abstract about the circulating blood biomarkers on the Javelin 100 trial. To remind you, the Javelin 100 trial is a trial that has established maintenance Bellmunt as a new standard of care in patients that do not progress after receiving first-line chemotherapy in metastatic bladder cancer. We already published the trial in the New England Journal in 2021, showing a survival benefit. And then we subsequently published some analysis in terms of biomarkers that this was accepted at Nature Medicine about the importance of the tumor mutational burden, and also a composite a set of markers in terms of molecular signatures, clinical signatures. And then what we have been presented here is additional study of biomarkers. We have presented that the presence, for example, of tertiary lymphoid structures in the tumor, that is something that has been seen in other tumor types, is predictive of a good outcome in patients receiving Bellmunt maintenance. And then we have applied a genomic signature that is the Javelin signature used in kidney cancer, an expression signature of immune genes. And also in this trial, we have seen that this Javelin signature is predictive of a good outcome in patients receiving Bellmunt. And then we have gone further, and we have explored the epigenomic space. And we have been using the EpiSwitch, that is a platform where 900 chromatin loops are being explored. And this is linked with a gene expression. And we have seen that there is a gene, the PO2F2, that whenever is a low express in the blood, that predicts that the patient is going to have a good outcome. In a different point of view, when we have explored the expression of these PO2F2 jointly in the tertiary lymphoid structures, we have seen that this is predictive of a good outcome. And the final observation is that tumor mutational burden is predictive of a good outcome overall in the trial. And we have found that in those patients that have this gene that is low in the chromatin conformational structures, joined with a low tumor mutational burden, we identify a subgroup of patients that are going to have a good outcome. We have seen other biomarkers. We have seen the biomarkers in the adjuvant nivolumab trial, the Checkmate 274. Dr. Nagy has presented that at the mini oral session, and also the known predictors interferon gamma signature have been shown to be predictive. Interestingly, he has presented that the CD4 expression seems to predict outcome, but not the CD8. And this was one of the questions that was raised during the presentation. Another biomarker presentation has been the analysis of the PESPER trial. They have also presented contradictory results in terms of that the basal signature seems not to be predictive of good response to the neoadjuvant chemotherapy. And this is in contradiction to the Sailor trials that predict that patients that have this basal squamous signature, they have a poor prognosis, but whenever they receive neoadjuvant chemotherapy, they have a much better outcome. So a lot of things on biomarkers that obviously with contradictory results, but we hope that in the future we are going to homogenize the way that we are analyzing the biomarkers and find some straightforward biomarkers for our patients receiving immunotherapy. In terms of clinical trials, we are awaiting today to see the results of the cohort K of the EB trial, where the results of the randomized comparison with enfortumab vedotin plus pembrolizumab. Enfortumab vedotin is an antibody-drug conjugate that is a new way to administer chemotherapy combined with immunotherapy with pembrolizumab compared to EB. The press release has tell us that there is a higher rate of responses. So this trial is going to shed light on the benefit of using this new way of combining chemotherapy, that is using antibody-drug conjugates and immunotherapy. We know that in the standard way of combining chemotherapy and immunotherapy, we have failed in first line. So this trial is in first line patients who are previously untreated. But it seems that using ADCs, the antibody-drug conjugates, plus immunotherapy, maybe we will be able to find some new good results in bladder cancer. We know that the combination of chemotherapy and immunotherapy has been helpful in lung cancer, in esophageal cancer, but not in bladder cancer. So several trials have failed when combining a standard chemotherapy with immunotherapy. So we have the hope that maybe, based on the results of this combination of EV-Pembro, the future is going to change for bladder cancer patients. Obviously, this is not a phase 3 trial. So the final results of the phase 3 trial, a trial that is named EV-302, likely are going to be released or reported in 1 year. And in this trial, patients previously untreated that can be fit or unfit have been randomized to receive EV-Pembro versus standard chemotherapy, that is platinum gemcitabine or carboplatinum gemcitabine. This trial is the one that we are hopeful that is going to change the standard in first line. So it seems that the promising results based on these trials that, as mentioned, the cohort K is going to be presented today, in fact, likely if the phase 3 trial is positive, we are going to see a change completely in the standard way that we are treating bladder cancer patients. So those has been, I think, the most striking data that we have seen in bladder cancer.